Automatic exposure control. This is the second half of the lecture that was supposed to be given last week, so just a hair behind, guys. I did announce that we're only quizzing on technique charts this Thursday, and so we'll roll this quiz back by 1 week. Might have it in double up quizzes in week 3, but you guys are tough. You can handle it. So anyway, let's get going on automatic exposure control so when the quiz does show up, you guys are ready for it. And remember, this stuff is on the midterm, so yeah, we'll be holding you accountable to it. We might have to, because we got behind, we'll have to play catch up, but it's on the midterm, so we got to sneak this other half of this lecture in somewhere, okay? All right, so they used to be called phototimers, and you'll still hear the gray hairs call them phototimers. That was actually the initial technology variation. So like generation 1 of an automatic exposure control device was a phototimer device. They'd put a fluorescent screen behind and then they put a light capturing diode or a light sensitivity meter, a light sensor meter behind that, and they'd put all this behind the image receptor. And so X-rays that penetrated all the way through the image receptor would hit the fluorescent screen would give off light, and then the photomultiplier tube would absorb the light, and that's the light detector. This was the technology of the 1940s and 50s. This is what we had. So the photomultiplier tube would amplify, would change the light into electrons and then amplify those electrons and make it into an electric current. But it always required over-penetration of the image receptor. You actually had to, you're relying on X-rays that not only penetrated the patient, the Bucky assembly, and the screen film cassette, but they're going through all of that, and then they're hitting a fluoroscopic screen behind everything. So not exactly ideal as far as capturing the remnant beam. You would have, when you're using AEC with the old phototimer system, remember for screen film, KVP was related to contrast, and so you would always be using a higher KV with an AEC with first generation AEC. But the name phototimer stuck, so people still say phototimer even though we're not using a fluorescent screen anymore. We're using an ion chamber now. The second generation of AECs were ion chambers in front of your image receptor, and that's the predominant model in the marketplace anymore. You don't see true phototimer technology anymore. It's too bulky, it's too cumbersome, and it's not as efficient at the job, it's not as effective at the job as the ion chamber design. The ion chamber design is a superior design. So our AECs in the modern era, probably since the mid-70s, mid-1970s, have been AEC design, ion chamber design, instead of fluorescent screens and photomultiplier tubes behind the cassette, the image receptor. Okay. Our gas ion chamber, that's actually the picture for the course on Schoology. I drew this on Microsoft Paint. You can see there's an anode there. If you look, there's little dots in the chamber. Those are nitrogen atoms. And then there's just a little T-shaped wire, and we've ripped the electrons away from that. That's the anode, so it's got little plus charges on there. And then over on the other side, that's our cathode. It's got extra electrons on a little T-shaped wire, and this will not conduct electricity until the neutral air inside the nitrogen atoms become ionized. And so until you bombard that air, that pocket of air with ionizing radiation, there is no electricity flowing from cathode to anode. But as soon as the air becomes ionized, then we can get an arc and we can get an electrical current flowing across this ion chamber. And so it kind of acts like a radiation sensitive switch. And when it absorbs enough radiation, it closes the circuit, activates the switch, and then you shut off the electricity to the X-ray tube by activating this switch, right? So it's a kill switch for the X-ray circuit, okay? But it's called AEC, and some people call it an automatic timer. Remember, photo timer? It's not a time-keeping device at all. It's a radiation threshold device, is what it is, okay? And that's critical to your understanding of it. It builds up a certain amount of ionizations in that trapped pocket of gas, and when it reaches a certain threshold of ionizations, then the conditions are right for conducting electricity, and you get an arc that flies across the ion chamber. And then the circuit is connected, and then you shut off the X-ray exposure, okay? All right, so the book, if you go into the Carroll book, it's a little bit more complex than that. There's an ion chamber, there's a ballast capacitor, and then there's this device called the thiatron, okay? And I think I'll go into that in just a little minute. So phototimer, see, 1942 technology. We've come a long way since that. So you would put a fluorescent screen in the bucky behind the film screen cassette, okay? And so X-rays that penetrated all the way through the film and out the other side, through the film cassette and out the other side, would hit the fluorescent screen and cause the fluorescent screen to glow. This gives off a light photon. The light photon enters a photomultiplier tube where it's turned into several light photons, and then at the very top of the photomultiplier tube, it's turned into all the electrons, all the light photons are turned into electrons that flow down a wire toward a capacitor. When the capacitor reaches its threshold charge, it discharges, drops all of that charge into an electromagnet that activates and opens the switch on the exposure circuit. Okay? So basically all versions of first generation, which is obsolete, which I just described, that we don't use anymore, and the new generation, the ion chamber version, they all involve a storage capacitor coupled to the ion chamber, coupled to the radiation detector device, and then a means to open the exposure switch by electromagnet, okay? It does not time at all. It doesn't keep time. There's no watch components. There's no vibrating quartz crystal or cesium atoms or anything like that. It's not a timekeeping device at all. It's a radiation counter, okay? And since you understand it's a radiation counter, one ionization turns into one electron, and then we start stacking electrons, and then that becomes current, because then we can push those electrons down a wire and it becomes current. If you understand that, then you understand how an AEC works, and you can understand how you can screw up using an AEC, which is basically the second half of this lecture. All right, so ion chambers, they're thin, flat rectangles. Typically, they're made out of like clamshell plastic. You know, you've ordered something or bought something in the store that the device was wrapped in. The best is a pair of scissors that they wrap in, because you need a pair of scissors in order to open the clamshell packaging. So if they sell, that's the ultimate irony, selling someone a pair of scissors that is wrapped in clamshell plastic. Well, if we take just a rectangular clamshell bubble and we fill it with nitrogen gas, and then we put a cathode and anode at each end in the inside of the air chamber, or plexiglass, because that's a little bit more durable than plastic. You can put that in between. It's basically radiolucent, except for the very, very thin wires that are the cathode and anode. It's basically radiolucent. You can put it in front of the image receptor, underneath the table surface, but above the bucky tray, or in the vertical bucky, just behind the front fiberboard panel. Okay, and you can arrange them. Typically, the early iterations of AECs are the Mickey Mouse configuration, right? 2 ears and a face. That is to a left and a right ion chamber, and then a center ion chamber. Sometimes they're called cells, like center cells, outer cells, that kind of thing. Modern DR units can have up to 5 ion chambers. I think GE has a version where they've got 5 ion chambers on their vertical bucky, which is confusing. No one knows how to use 5 ion chambers, so only people have worked with that particular model of GE equipment. Okay. All right, so the components of the circuit. This is not registry content necessarily. I've never seen a schematic for an AEC circuit on the registry, but it's helpful since you guys are familiar with schematic. It's helpful. We're going to introduce a new device called a thiatron. The thiatron basically regulates the sensitivity of the ion chamber and capacitor combo. So the ion chamber and the ballast capacitor, which is at B, they kind of are catching charges, they're making charges, and then the B is storing those charges and waiting to override the thiatron. The thiatron, in this case, it's second cousin to a capacitor, and it has to be overpowered, and it's an adjustable capacitor. Okay, it is a vacuum evacuated, and it's got a cathode and anode, and by adjusting the voltage applied to the thiatron, you can adjust how much charge B, the ballast capacitor, has to build up before it can override the thiatron, and that's really what's happening. So the thiatron is like a capacitor that is fighting the capacitor at B, but you get to set the strength or the weakness of the fighting capacitor, the thiatron. Okay, so B is all about activating the relay at D. It wants to send its excess charge to D, where there's an electromagnet at E that can pull open the exposure circuit. Okay, and so when A, the ion chamber, starts collecting ions, it sends those ions to B, the capacitor, and the capacitor starts building charge. It wants to discharge to D, the electromagnet, but it can't do that because the thiatron is fighting it. The thiatron is a capacitor that's pushing against the charge building up at B. But after a certain time, as it keeps collecting ions from the ionization chamber, eventually it will build up more charge and it can overcome the thiatron. When it does that, it sends current to the electromagnet at E through the relay, and the electromagnet activates and pulls open the exposure circuit. Make sense? Good. All right, so that means that we have to build ions in the ion chamber, and we have to collect them. Typically, collecting them at the capacitor is not the problem. It's making the ionizations at the ion chamber. That's the problem. Do we have the right technique? Have we set adequate kVp? That's the first answer, because our patient has got a certain thickness, and if we don't have an adequate penetration power, then we're never creating ions in that chamber. Okay? But once the chamber collects enough ions and the capacitor at B builds a strong enough charge, it reaches what's called the charge threshold and releases a surge of electricity past the thiatron to activate the relay and open the and pull on the electromagnet to open the exposure circuit. And as we know about electricity, only closed circuits conduct electricity. So as soon as the electromagnet breaks the circuit at E, the exposure terminates. Okay, and then the whole thing resets, the capacitor grounds out, and the electromagnet no longer experiences current, and then it relaxes and there's a spring that reconnects. So the electromagnet's fighting a spring the whole time. And there's a spring that reconnects the circuit at the relay and at E. And the only way to overcome that spring is to power up the electromagnet again, which it basically resets it for the next exposure. So, two main switches will control the main circuit at this point when you activate AEC. You can always let off the exposure switch manually. You know, you're still holding down the button. But if the capacitor, the ballast capacitor at B, stores the threshold charge such that it can always with this, please. Hang on just a second. Sorry about that. Okay, so I don't think I started this slide at all. Let's get right into it. Oh yeah, I did. So the AEC, if the AEC circuit actually sends charge to the relay, then the exposure will also terminate. Okay, so two ways, once AEC is activated, two ways the exposure can terminate. Actually three ways because there's a backup timer too. We'll get to that in a minute. All right. So, described in detail in Chapter 8. Okay, that's the part we skipped over. You can go back to that. You're welcome to go back to that. I skipped over it for the physics course because I knew I was covering it this fall in this amount of detail. So, electrical charge from the induced current in the ion chamber is stored at the, what I call the ballast capacitor. Okay, what is it ballasting? It's ballasting or being a counterbalance to the capacitance at the thiatron. Okay, until the preset threshold for correct exposure is reached. Where do we set that preset threshold? The thiatron. The thiatron determines what is the override threshold. The thiatron's whole job is to stop the storage the ballast capacitor at B from sending the shutoff signal. But once it gets past a certain number of a certain like volume of charge, then the thiatron knows that okay, I can't impede this anymore. I've got to let the current flow and I've got to kick off. Now what is that? What does that correspond to? That corresponds to a certain strength of remnant signal, okay? Like photons hitting the ion chamber. So as, let's say we need, I don't know, like 2 billion photons to hit the image receptor. But in order to do that, we like compute the ratios of the size of the ion chamber to the size of the entire image receptor, and we figure out that that's equivalent to about 100,000 photons being captured by the ion chamber. All right, and so we set our thiatron to that. And so when B builds up of charge equivalent to about 100,000 electrons, then that's going to overpower the thiatron. That's the threshold. And we're going to let the charge run to the relay at that point, okay? But until that time, if B only has 20,000 charges stored, then we're not going to allow the exposure to terminate. It has to keep building charge until it gets to 100,000. Because if it gets to 100,000, that's the equivalent of the entire image receptor getting about 2 billion photons, which is like an adequate remnant signal strength. Okay, I'm just making up these numbers. I don't know what the real world scenario. I don't know if 2 billion is an adequate signal strength or not. I'm just making up the numbers so you can understand what's going on. It's like these circuit elements are making decisions for us. So you need to understand the decisions they're making and how it is a mechanical object is, or electrical component is making that decision. It's We've got capacitors, a special type of capacitor called the thiotron, where we can actually tune the amount of charge that it's holding. And so in order for B to override that, it's got to build a stronger charge. Okay. So like I was saying, AEC does not time anything. AEC counts radiation, remnant radiation in particular, not primary beam. It's not calibrated to count primary beam radiation, which is also one of the downfalls of AEC. Okay? So we've already talked about part thickness, and now we've talked about it's meant to count remnant radiation, not primary radiation, which is more intense, remnant or primary radiation. And that's a clue as to what can go wrong with an AEC. Okay? So when a patient's rolled onto her side, or a larger patient is radiographed, body part is thicker, exposure rate is reduced. That is, the remnant beam thins out because the body is thicker now, and so it's absorbing more of the primary radiation. So it takes longer for threshold ionization to be achieved. Okay? And so if you're shooting AEC's AP lumbar spines, and then you shoot AEC lateral lumbar spines, and everything else is the same, your lateral lumbar spine exposures are going to run longer because you're going through twice the thickness of anatomy. Okay? Optimally, MA and optimum KV are still determined by the radiographer. How do you reduce the exposure time for the lateral lumbar spine if you're using AEC? You should increase the technique, increase the kilovoltage when you switch from AP to lateral, because your part thickness is increasing. Okay, and we talked about that when we talked about technique charts last week. Okay, minimum response time. I demonstrated this with the overhead lights. Any electric circuit's got a little bit of lag. If there's capacitors involved, you definitely have lag. It becomes a noticeable lag because capacitors take a while to discharge. They have what's called a static voltage. If you talk to an electrician, they're going to talk about the strength of the capacitor as if it's static voltage, but they convert that static voltage to, when a capacitor is allowed to discharge, it converts the static voltage into conventional voltage, which eventually converts into current. So static, when a capacitor discharges, electricians like to say static voltage is converted into a boost to amperage temporarily. Okay. So when high power equipment is combined with smaller body parts, such as pediatric patients, possible for overexposure because you have a minimum response time. So the expected response time for like a pediatric extremity might be like 0.002 seconds. I think he might give an example on the next page, but the AEC can't terminate until 0.02 seconds. That's problematic. You're giving 10 times the dose. Okay, so the backup timer does two things. Okay, so minimum response time is the idea that sometimes it's appropriate to manual technique because your AEC can't turn off fast enough. Okay, backup time, sometimes it's always appropriate to have a backup time in your AEC software because sometimes you never achieve threshold ionization. If the body part is too thick, then you're never stacking ions in the chamber or in the ballast capacitor, right? Because your remnant beam's so thin that nothing's getting to the ion chamber, okay? So the backup time should be at least 2 times the expected exposure. So you should have a reasonable idea of where you think, even if you're using AEC, you should have an idea of what mass you're going to be drawing, and then the backup time should be about twice what that is, okay? Because you don't want to underexpose, okay? Because that would be the thing that would lead to a repeat. The point of a backup timer is you don't want AEC, if the AEC never counts radiation at the ion chamber because your patient's too thick, your exposure will just keep going and going and going until you let off the button or you blow up the tube with heat. Okay? And then if you're doing that, are you overdosing your patient? You bet your butt you're overdosing your patient. So inadequate KV with too thick a body part, that's a recipe for disaster. Okay? You don't have enough penetration power, body part's too thick, no ions are being created in the chamber, no charges are being stored in the capacitor, so the exposure just keeps running and running and running until you get a clue and let your thumb off the button. And if nothing's reaching the ion chamber, nothing's reaching the image receptor either. And so you don't have an image and you just dosed your patient for nothing. Okay, so you can get in trouble with AEC if you don't have adequate kilovoltage. Okay, the backup timer is saving you from ridiculously overexposing your patient and overheating your X-ray tube. All right, so in some of the older units, you can activate the table bucking mechanism when you're at the wall bucking. Now the newer equipment has a safety lockout and won't let you expose. Okay, it can tell if you fed a cassette into that bucky. So if you've got a digital detector that you can change it from the table to the wall bucky, you activate the wall bucky, but you put the detector into the table bucky, it's going to say you're confusing me because the image receptor's in the table, but you've activated the wall cells. Do you mean to activate the table cells? And you'll say yes. Okay. And then also the density control, which is obsolete. But I'll talk to you about the density control. You can actually adjust the sensitivity of the thiatron and then therefore adjust the threshold that the ballast transformer or the ballast capacitor needs to reach. And that's the plus or minus setting. A plus setting on density means you're going to let the exposure run longer and you're going to increase the threshold that needs to be reached. A minus density setting means you're going to make the AEC trip easier with less radiation, and so the exposure is going to be shorter. Okay. So density and automatic rescaling. Density was made for screen film technology where the exposure actually determined the brightness or darkness of the film. Okay. It doesn't make sense anymore. It's completely obsolete in digital technology. CR and DR both have a software subroutine that you're going to learn about this spring called automatic rescaling. Basically, if the raw data, the photon intensities that you record on the CR plate or on the DR array, they go to the computer looks at the numbers in the array, in the matrix, and say, all these intensities are 3 times too high from what I'm expecting. The heck am I supposed to do with this? I know, I'll divide all the intensities by 3, and then I'll send them off to the processing software. That's basically what automatic rescaling is do. It's taking your overexposed technique and scaling it back to a range of values that the computer is expecting, okay, for the next batch in the software. So automatic exposure control. So if you adjust the density button for increased density, the exposure is going to run long, your remnant beam strength is going to increase, but then if it's out of the range for the software, you're going to the software is going to divide all those intensities by 2 or by 3 or some other number so the intensity that you stacked and the remnant beam strength that you stacked, yeah, the automatic exposure, or not the automatic exposure control, the automatic rescaling software undoes what you did with the density button. It counteracts the action of the density button. So that's why I say the density button is obsolete. Shouldn't be using the density button. The only thing you're doing, especially if you're going to +1 density or +2 density, you're just increasing patient dose, because the rescaling software is trimming back the intensities of your raw signals into the range of what. And you can do that with manual technique too. Automatic rescaling software, anytime you're overexposing more than what the manufacturer recommends, the software subroutine that's called automatic rescaling is rolling back your exposure values to a fraction of what they were. Okay? But the patient still gets 2 and 3 times the dose. So, the software is great. It's making you guys look like Rembrandt. Okay? So, rescaling. All the raw data looks like this, and that looks like a crappy x-ray, washed out with low contrast. If I saw that, I would, and that was the final image, I would say way too much scatter. We don't have any contrast here. We've got dirty dishwater gray, and then we got slightly darker gray. We got 2 colors here in the grayscale. Okay. This is raw data. It has to be reprocessed yet. And one of the first things it does is, are the intensity values in the expected range? They have in the software, they actually have saved intensity files that they match up with yours in order to judge whether you're overexposed or not. Okay? It's called a reference histogram. You'll learn about that more in the spring. Okay? So when they rescale it, it relabels your incoming data. It basically fractions the intensity. So in screen film, those are the examples at the top. Underexposed, optimal exposure, overexposed. No, all of those in digital age look like the bottom one. Okay? So you can underexpose in screen film, but it can be scaled up. Rescaling can be applied either way. We can also multiply all your intensities. Say you use 75% of what was recommended. Automatic rescaling can multiply all your intensities by 1 1/4. And so it scales it back up to what it's expecting to. But typically it's the tech overexposes and it's got to trim back all the intensities. Okay, and so that's actually one of the flaws that creates dose creep, is there's no visual cue that you overexposed anymore. In screen film, we would see the image. If we overexposed the knee, we would see the image on the far right. Okay. If we hit the window of optimal technique, we would see the middle image and we would be very happy, and the radiologist would scream at us. And then if we underexposed, we saw the image on the far left. Okay. But you guys overexpose up to 75% of what you're supposed to use, all the way to optimal technique, all the way to 6 times what you're supposed to use, and you still see the bottom image. And so there's no true feedback that your techniquing is not as good as it could be. Okay. You got to dig a little and go into the DICOM data, and most techs don't even know how to do that. So density adjustments, as described by Carol in the chapter about AEC, will not result in a darker image. And this is all my warning, because the AEC density button is antagonized by the automatic rescaling software. They work against each other. The exposure will run longer, and you will increase patient dose, but your image will not get darker. Your remnant beam strength will be stronger, but that doesn't translate to any visual parameters. Brightness and contrast are set by the software, not by the signal strength. Okay? So a better adjustment to correct for weak signal in the digital age, instead of density plus, increase your KVP instead. Okay? AEC was not intended to be used on all procedures or to be used as a crutch to avoid setting techniques. AEC, if the body part or the anatomy of interest cannot cover the entire chamber, then you shouldn't be using AEC. The detectors average the exposure across the entire area. So if raw primary radiation is reaching the ion chamber because you're not covering the entire ion chamber with a body part like a finger, um, the primary radiation is going to build ions very rapidly. Charge is going to build very rapidly, and exposure is going to terminate prematurely. So prematurely that you'll probably cause mottle, which is a new one for a finger. So don't use AECs for any body parts that are smaller than the AEC chamber itself. Okay? So clavicle, mandible, lateral sternum, scapula, um, lateral scapula. Okay? Fingers. I would even say hands and wrists. Forearms, yeah. Elbows, yeah. Don't use AEC for those. Humerus, you can probably get away with it. Humerus is where the part first gets thick enough that you can probably cover the whole cell, the whole chamber. Okay? If primary radiation strikes your AEC, remember the thing is calibrated to measure remnant radiation, which is much, much less intense than primary radiation. So raw primary beam will always shut off your AEC prematurely and you'll be underexposed. Okay? So what's the key to using AEC well? Activate the correct cell, and the pertinent anatomy has to be covering and centered to that cell and covering that cell. If you activate more than one cell, all the activated cells have to be covered. Okay? So basically we're talking about probably humerus, probably femur, and the trunk. And then maybe center cell skull. I'll give you that. And that's it. Anything below the elbow, anything below the knee, any pediatric patient, you shouldn't be using AECs for that. Okay? AEC should never be used when there's any type of radiopaque surgical apparatus. Artificial hip that's a big chunk of metal. So if they have an orthopedic implant, that's a big chunk of metal. What is the AEC actually measuring? Is it counting exposure time? No, it's counting ionizations. And so if there's a big chunk of metal right in front of the chamber, what's going to happen to the primary beam when it hits that prosthetic? It's going to be absorbed by the prosthetic. So what's the remnant beam right behind the prosthetic? It's basically got no photons at all. So if the prosthetic is covering the chamber, you're never going to achieve ionization, and you're going to overexpose. You're going to reach backup time more often than not, and you're going to see a white prosthetic, and then you're going to see, maybe you'll see part of the pelvis, and then the rest of the image will be way too dark because you'll be overexposed. Okay, and it'll also affect your histogram. Okay, so what's the better way? You got a manual technique when they have hip replacements, knee replacement, total joint replacement. If they say that they have an artificial hip, just ask them, assess. Have you had this hip replaced? Turn off the AECs if they have. Okay. Spine fusions, not so much. You can still use AECs on spine fusions. Okay. But something the size of a complete total hip replacement, oh yeah, it's going to affect the AEC. Okay, so just manual technique that thing. Okay. So there you go. There's an example of a artificial hip being phototimed or using AEC. And then here's the other one, the AP open mouth. Didn't account for the mandible with dentures and the maxilla with dentures also being in the chamber, and so we ended up running the exposure log. Now both of these are on film, so it does affect the overall density. It won't look as bad on digital, but it'll look bad. All right, so your detector cell configuration. Typically it's a 2-inch, 1.5 to 2-inch wide by 3-inch long rectangle, indicated by where it's outlined on the detector. Now the table doesn't have the indicator because that bucky slides up and down the base of the table. And so you got to just, if you're using the AECs in the table bucky, you just kind of guess where they are. Okay, they're basically in the same location as they are in the wall bucky compared to where the image receptor is. All right. So different projections require different active cells, and he goes into this big spiel about you should really use center cells for PA chest. I disagree. Okay, maybe it's just here in the South we grow the people a little bit bigger. I've never had the problem he describes where part of the chambers over the mediastinum. I've never had that happen. Okay, usually my chambers are over the middle to upper lobes, so I'm not sure. He wastes about 4 pages of the chapter on it, and it's like, okay, all right, maybe if the person is 5 foot tall and they got little bitty lungs, yes, you're going to have overlap of mediastinal and the heart shadow over, especially that left chamber. But I mean, that's the exception, not the rule. If you're over the center cell, then you're just over the spine and the heart, and the lungs are going to be overexposed. So I would still rather do outer cells for the PA chest. Okay, but this is not how you do a hip. The chamber should not be over. That chamber is over soft tissue and the beginning of the shaft. It's not even over the trochanter. The chamber should be over the acetabulum, the femoral head, and the structures of the pelvis, and the gluteus maximus muscle. See the skin fold there? Okay, so you can tell the body part is thinner, the bone is thinner, there's not as much bone, so of course it's going to expose prematurely. It's going to terminate the exposure prematurely. The tissue is easier to penetrate where we've got highlighted. So center to the hip next time and shoot, and then it won't be underpenetrated. See how you can't barely see the femoral head and the acetabulum? You can see a little bit of the ischium, right, and the border of the pelvis. But no, if you centered over where the hip actually was, instead of, you got optimal penetration of the shaft, but that's not the area of interest. The area of interest is the hip, the femoral head, and the acetabulum. So put that over the active ion chamber. Next, align the active center cell. I'm not saying you can't shoot a hip with center cell. I'm saying your centering is going to be on point if you don't want an underexposed one. Because if you're centered over the shaft, then you don't have enough X-ray to get through the pelvis adequately. Okay, those are two different part thicknesses. All right, so this is it. This is his, right? For me, my criticism is his chambers are out of scale with the size of the lung fields. Okay. Remember, the chambers are only about 1 inch across, 2 inches long. All right. So that means that lung is only 7 inches from top to bottom. That's ridiculous. Lungs are not 7 inches from top to bottom. Lungs are more like 14 to 15 inches top to bottom. Okay, so he's got a very tiny person here. Not only that, but he's centered way too low. Okay, he's supposed to center at 7. Right, he's centered probably at T9 for this, based on the location of the chambers. So he's clipping the apices too. But that would also mean that a much smaller chamber would actually be in the lobes, in the upper lobes, upper to middle lobes of the lungs. Okay, B is still going to be superimposed. The bottom corner of B is still going to be superimposed by the left ventricle, but it's not going to be like this. Is centered about somewhere between 4 and 6 inches too low. That's why it's ridiculous. And he goes on, and it's just the whole time I was like, really? Your diagram isn't even, it's not to scale. The scale of that human lung to that AEC chamber is out of whack. Either the lung is very, very tiny, or you have a giant ion chamber. Okay, and then the centering is not right according to where it's so the middle of chamber C, that's the middle of the exposure field. At the diaphragm, T9, T10, I thought we were supposed to center at T7, which would be 4 inches north of there, halfway between where the diaphragm is and where the aortic arch is. So you can see the chambers are purposely mispositioned and purposely too large. All right, so this is weird. It's got so much, the diagram is so flawed that it's problematic. The analysis is problematic. Okay? I should write a critique on it. So this kind of thing, I mean, all it seeks to do is, yes, I do want you to get the idea in mind that what you put in front of the chamber matters, but I want you to have a realistic example, not this. This diagram is crap. All right, so how can you screw up with AEC? Activate the table bucky when you're positioning at the wall, at the upright bucky. Okay? Only the older equipment can do that. Everything else is going to give you the fail-safe lockout. The new stuff is going to say, no, you're doing it wrong. Okay, need to fix it before I'm going to expose. Needed exposure time is less than the minimum response time. This is typically your pediatric chest. Don't use AECs for pediatrics. Okay. The density control left on the plus setting from previous patient. Well, the way to avoid that is Mr. Tillotson has told you the density controls are obsolete in the digital age. Stop using them. If you want the exposure to run shorter, increase KV. If you want the exposure to run longer, decrease KV. Because more penetration means more ionizations, means the chamber shuts off faster. Less penetration means less ionizations, means the chamber shuts off slower. See how that works? Okay, so KVP has got an inverse relationship to exposure time when you use an AEC. Electronic malfunction of the AEC. It's an electric device, just like anything else. Does a light bulb ever blow out? Does a capacitor ever blow out? Does an ion chamber ever blow out? Yeah. Does a thiatron ever fail? Yeah, all those things can happen. Okay, and so your AEC might fail. Okay, if you've been using the AEC and you notice that you just keep hitting the backup timer, no matter what size your patient is, yeah, you might want to call Biomed. All right, incorrect detector cell configuration. Okay. You get in such a hurry, not you guys are thorough and careful. Your technologist gets in such a hurry they don't even switch the active cells. And they got a really skinny patient for a chest x-ray 2 view. They use outer cells, they get a perfect one, and then they position for the lateral, but the patient's real skinny. The outer cells are actually outside of the rib cage for this patient. And they leave the outer cells active for the lateral, and primary radiation hits the outer cells because the patient's really skinny, and the exposure terminates prematurely and it's underexposed. You got to shoot it again. So make sure that as you're switching positions, do I need to switch the active cells from the outer to the center? That's a common thing that has to be done. Okay. Radiopaque artifacts. You got to interview your patient. You got to assess. Do they have a prosthetic, especially if you're doing that hip radiograph, because that's the one that'll a knee. You can probably get away with it. Okay, a knee looks a little, you lose some contrast. The contrast becomes a shorter scale. Anyway, regardless if you manual technique, a full total knee replacement, fully prosthetic knee, or if you AEC it. But a hip will always look like garbage if you AEC it, if it's a total hip. Okay, so ask, have you ever had your hip replaced? Okay, if the answer is yes, don't do the AEC, do a manual technique. Now, what's your manual technique? You've forgotten it because you do AEC center cells on all your hips. Okay, for Senecavitis, digital age, your DR plate, I'm going to say 85 at 10 mass is going to get it for your sthenic habitus. And same thing for your frog leg. If you're going to do the cross table, do 90 to 95 kV for a cross table prosthetic. Oh, you got to do a manual technique on that one regardless, because you can't use AEC on a cross table. Patient's body weight divided by 2 for the mass. Okay. So radiopaque artifacts will let the AEC run long. Lead shields, lead sheets, or sandbags in the exposure field over the chamber will also make the exposure run long. Remember, we're counting radiation. We count radiation by counting ionizations, turning them into stored charges. We are not actually using any timing device in an AEC. All right, so there's a nice little table describing all the things. Now, the previous one was overexposure. This is how you get underexposure with an AEC. So again, density control adjusted to the minus setting. Backup time shorter than needed exposure time. So your backup time is not twice the expected exposure. It's like more like half the expected exposure. Yeah. So check your backup time, make sure it's adequate. Incorrect detector cell configuration. Activated cells lie under tissue less dense. So the other one was tissue that was more dense. Okay. And then the entire detector cell, the entire chamber, not covered completely. Okay. This would be your fingers, your hands, your wrists, any situation where you have an active chamber AEC, but raw primary radiation is hitting that active chamber, yeah, it's going to terminate prematurely. Okay? It's calibrated to measure and catch and count remnant beam signal strength, not primary beam signal strength. Okay? So, you need to set the correct kV for adequate penetration still. No change in MA compensates for inadequate penetration. Okay? In fact, that's a great way to overdose your patient. High MA, high backup time, but the KVP is inadequate to penetrate. Like if you're using 50 for a lumbar spine AP, right? And you set a backup time for 600 mass, what's the final exposure technique? 50 kV at 600 mass. Because there's no way you're creating ionizations. No way you're getting through. 50 kV does not penetrate through the abdomen. You need at least 70 for asthenic. So inadequate kV cannot compensate. Inadequate penetration power cannot compensate for any density adjustments or any adjustments to the MA or the backup time. A small focal spot should be used for extremities. I don't know why we put this in here, because you shouldn't be using AEC with extremities. Okay? Proper detector cell configuration must be selected when you go from PA to lateral chest. Switch from the outer cells to the center cell. Okay? APR. Now, Carroll does a great disservice to APR, considering how prolific it is in the modern era. That's because Carroll has gray hair and he's used to technique charts, and a proper technologist will make their own spreadsheet, publish their own technique chart. So only you button pushers will dare to use the APR. How can you trust the machine? All right, so APR, anatomically programmed radiography. You've been using it this whole time. You just don't know what to call it. I don't know why the texts don't call it APR. Texts just say, just tell the machine what you want to use, just dial up, right? Okay, but what software is that? That's APR, anatomically programmed radiography. So we are blessed in the digital age that the software for the control panel, you can tell it what projection, what body part, what projection, PA chest. Sthenic habitus is the default. And it's going to suggest to you a technique that the manufacturer has tested on what do you call those, phantoms. And so typically you find, I would say greater than 90% of the time, those preset techniques are perfect. Okay, they work. Not only that, but there's habitus adjustment buttons. Okay, depending upon how diligent your technologist is, they'll know about the habitus adjustment buttons or not. But usually you can scale, and what it'll do is if you go to the small, it'll scale it down. Okay? So the APR, according to Carol, should be starting points for technique. Okay? But you need to take into account SID, grid use, that kind of stuff. Okay? They can and should be overridden as needed. All right? So, and he says the accuracy, and I do agree with that statement, the accuracy and goodness of these techniques vary by the manufacturer, but in my experience, that goodness is 90% reliable or better in most occasions. Typically where I find the pre-programmed APR techniques fall apart is where the very extremes of habitus, either the extra large habitus or the asthenic habitus or the pediatric patient, which is essentially a tiny adult. Okay, so that's APR. APR, I mean, there's not a whole lot I can tell you about it in the book that you don't already know. So if you're setting techniques out there in clinical education, you're already using the APR. Okay. So here's the summary. Yeah, this is all the stuff we covered in this lecture. So quiz on it will not be this week. Quiz on it will be next week. Okay, and so expect 2 quizzes for next imaging equipment class. I might make one of them an online quiz if you're nice to me. All right, take care.